عايض؟
نعم موجود.
Are we good?
Yep. It's clear. It's okay. Good attendee number ما شاء الله.
ما شاء الله is good.
شباب في الكنترول are we ready؟
Hello.
I think 3 minutes or 2 minutes to go إن شاء الله. I don't know the شباب في الكنترول are we okay؟ الأخوان تسمعوني في الكنترول وفي ممتاز. المحاضرة حتبدأ خلال دقيقتين إن شاء الله. حياكم الله جميعا. معنا الدكتور عوض العمري، استشاري العناية المركزة والأمراض المعدية والانفكشن كنترول، مجموعة الدكتور سليمان الحبيب الطبية، وذا بريزيدنت اوف Saudi Critical Care Society. About 1 minute إن شاء الله to go. A good attendee ما شاء الله. We are crossing ما شاء الله 4,500 ما شاء الله attendees. عليكم السلام ورحمة الله للجميع. حياكم الله جميعا. اعتماد ساعتين للمحاضرة هذه بإذن الله. مدة المحاضرة ساعة، منها نص ساعة إلى 45 دقيقة المحاضرة، وبقية إن شاء الله للأسئلة جميعا إن شاء الله. حياكم الله جميعا. أخوان في الكنترول can we start؟ طيب بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين. We are welcoming you everybody on board now with the first webinar with the Saudi Society Critical Care of Adult Critical Care chapter with the president of Society, Dr. Awad Al-Omari, the consultant of critical care medicine, and the infectious disease consultant, the vice president for the academic affairs at Dr. Sulaiman Al-Habib Hospital. Without any delay, I will leave you with the speaker now. Dr. Awad, can you please start?
Assalamu alaikum. Thank you, Mr. Chairman. Thank you, everybody, for their attendee. Thank you for the Saudi Council team for this excellent and amazing preparation. The team, they were working with us since a couple of days, and they had been with us since 9 o'clock to prepare this webinar. Thank you, Dr. Ayed, the chairman of this webinar, and I hope it will be a successful night. I will start by a question to the attendees. They are approaching 6,000 now. How many of you guys working in critical care? Yes, no. How many of you? Excellent. So around 50% are critical care background, and around almost 50-50, 52% versus 49. So the second question before we start this activity, do you think, guys, do you think the Tele ICU module is effective method in managing critical care community hospitals? What do you think? Tele ICU, is it effective in managing community hospitals where there is no consultants most of the time, or you think no? Excellent, amazing. I was not expecting this answer. So 85%, they are buying the concept. 15%, they are not buying the concept. So thank you, you are making my life easy. So just before we will start, we'll tell you tonight we'll speak about ICU future need, intensivist, supply and demands, critical care services in this country, intensivist shortage, why we have an intensivist shortage, and Tele ICU global experience and our local experience. First of all, the good news, the people are aging. And in 2012, if you look to the population over the world, there is 12% of people above 65. In 2025, there will be 17%. In 2040, almost there will be 1.5 billion are above 65. So it's around 20% of the whole people living in the world above 65. And this study from Norway came almost 10 years ago, showed when people they are aging, which is totally makes sense, the demands for critical care beds are more. And USA Department of Health and Human Services, they were anticipating this issue since long time. And they were anticipating almost 38% deficiencies of intensivists by 2020. And we are 2020 now, and this was before Corona pandemics. And I'm sure with Corona pandemics, this number is almost approaching 60% deficiencies of intensivist time being, because more demand for critical care beds. So unfortunately, we have a major issue here. The demands are far away more than the supply. So the previous numbers published in JAMA showed by 2030, we are expecting 35% shortage of an intensivist. The question why? And again, before we will go to that question, here in critical, in Saudi Arabia, we published this article in almost 2003, and we were looking to different style of critical care in the different hospitals. As you know, most of our hospitals in this country divided between primary, secondary, and tertiary hospitals. Primary hospitals account the highest among the whole hospitals in the country, more than 2,000 hospitals. In the primary hospitals, usually we have a very small ICU for emergencies. However, we don't have the full trained staff, we don't have consultants, and we don't have that expert nurses. In secondary hospitals, we have an open ICU, and we have a very good equipped ICU, but again, the problem in the manpower. And again, the problem in manpower exists even in tertiary hospitals. And you look here, the intensivist to bed ratio in Riyadh, when we did our study in 2014, was for every 37 bed, there is one intensivist. When you compare it to the USA data, that was one intensivist for every 7.5 beds. That was 6 years ago. The big question the people usually they ask, and my HR is usually asking me, and my boss at work asking me, why you cannot recruit an intensivist, and why we are giving a big budget for the intensivist, and even we cannot bring them in. Again, the atmosphere in ICU is a little bit complicated. As you know, at least 50% of you guys work in ICU. It's a lot of stress, a lot of headache, too much responsibility, dealing with sick population, dealing with this, deaths, bloody nights, as usually we mention, and unfortunately, you have to deal with sicky type of patients. And I found this is a very interesting survey. It was published in Medscape in 2008, when they asked physicians about their happiness at work. Our colleagues in ophthalmology, they were the most happy doctors at their work, then the plastic surgeon, pathologist, dermatologist. If you look to critical care was down on the list, almost we are with the internal medicine and cardiology are not a happy specialties. If you look to physician burnout, if they are depressed or not, you will find critical care on top of the list with neurology. On the other hand, you will find plastic surgeon and dermatology are happier than us, probably because of the type of patients they will see different from critically ill patients. And again, another survey, did the intensivist feel fairly compensated? 56% of the people, they are happy about their compensation, but again, there is a big portion of the intensivists, they are not happy about their or satisfied about their compensation, and they look for more. So all the surveys shows people are not happy, are not satisfied. This is another study looked to burnout syndrome in critical care. I found it a very interesting study because if you look all over the world, in Portugal, in Brazil, in Australia, in Lithuania, in different regions, results are similar. There is a sign of psychological stress. There are at least 1 or 2 criteria or high-level burnout. There is emotional dissatisfaction. So all of it are risk factor for high burnout in critical care. Small study done in 2017 in our area of the world, and it showed the same result. This is what the intensivists they look like. You see them every day carrying their mug of coffee, doing their rounds. I hope they are not burned out really when they do their rounds. And because all of that's evidence, there was a call for action between many societies worldwide, looking how we're gonna solve this major issue. It's a major issue. Why? Because if you look, for example, in US, the average turnover rate for employees, it was 10%. If you look to nursing, it was almost 20%, so it's doubled. And that will lead to a huge cost to replace them. So if you're gonna bring a good ICU nurse with a good experience, you will pay a lot of money to replace her, to train her, to educate her from the beginning. And we know the ICU, in the ICU, the nurses are the really background of ICU. So thank you for all of our nursing staff. Again, our RTs, our physicians, our pharmacists, our nutritionists, thank you for them, and are very difficult to replace them. So based on the high demands, people are aging, lack of supplies, and also it's not an attractive environment. People, they started thinking about using technology to try to solve part of the problem. And by the way, if I will ask you 6 months ago about your feeling of attending this webinar, I'm sure 85% they will not attend the webinar, because the people, they were looking for attending the conferences and they feel the online training is not the best option. However, Corona pandemic showed to us doing online training is an excellent, easy, and a cost-effective method. Now I'm giving this lecture to 8,000 attendees. If I'm giving this lecture on our annual conference, probably only 300 or 200 people, they will be there. So this is the difference, and this is the advantage of technology. So the background of telemedicine was almost started from 1950 by almost doing some sorts of teleradiology. Then with time, it was getting more mature and more advanced till moved out to become a telemedicine. Then we are talking about the most complicated form of the telemedicine, which is the Tele ICU. The advantage of Tele ICU, we are trying to have an expert people or expert consultant. We are trying to help the community hospitals when there is no consultant available, especially in primary and tertiary hospitals. When you have a command center and we have one consultant communicating with the nurses, communicating with the RTs, communicating with the resident or specialist there, massive change in the outcome will happen, because ICU is not only about procedure, ICU about quick decisions and quality assurance. This study was done in one of the best centers in the world, UMass Medical Center. So it was the first center they applied their innovative telemedicine. And this is, by the way, one of the best centers in the world. They put their command center, they were looking to 3 centers together 24/7 remotely. There was an intensivist at the bedside, but there was a telecommand center monitoring delivery 24/7, doing an auditing for the best practice. And there was a consultant intensivist who's reviewing the lab, radiology, and doing second opinion and doing an auditing all the time from the command center. And this was published in one of the best journals in JAMA 2011. Very interesting results in the best center in the world. When they compare between pre and post intervention, pre-Tele ICU and after Tele ICU, they found a very significant result. Look, stress ulcer prophylaxis improved by 15%. And we think as an intensivist, we are good in putting prophylaxis, but we are not. See the best center in the world, 15% improvement. DVT prophylaxis, 17% improvement. Acute coronary syndrome treatment protocol, it's improved by 23%. VAB prevention, which is a basic in ICU, it's improved by almost 57%. Why? Because there is a team, expert team, sitting in a room, looking carefully to the patient 24/7, and auditing and correcting people mistakes. And we know the ICU, the intensivists, the nurses, the RTs, they are busy, overwhelmed, shortage of staff all the time. And this is a good area to intervene and do the intervention and change the outcome. And again, you look to hospital mortality rate was dropped by 13%, which is a very significant outcome, and almost done in 6,290 patients, pre and before So the pre-intervention, there was almost 200 patients. After Tele ICU group, there was almost 500 patients. ICU mortality rate dropped by 20%. Hospital length of stay dropped by 26%. Another very significant results. And ICU length of stay dropped by 30%. So I will conclude that study. I think it changed a lot of thinking about Tele ICU since 2011. In Orlando Healthcare, they applied another study. Almost they have big numbers of beds, 1,780 beds. They have 8 hospitals. They are serving 2 million population in that area. They did their study with a different protocol. The Tele ICU team, they are looking for the patients from almost 4 o'clock after the handover till the next day. And this is what I call it usually the critical period. Why it's critical period? Because in every ICU, there is a consultant in-house from 8 to 4. But after the consultant will leave the ICU from 8 to 4, most of the administration in the hospital, they will leave. Most of the surgeons, they will leave. Senior people are not around. Then you will leave a specialist or junior resident alone in critical care units. Some of them are very busy. And then the complications start to happen. One resident or specialist admit 8 or 9 sick patients. He will miss either DVT prophylaxis or mismanagement of septic shock or a cardiac shock or whatever type of treatment. And this is the advantage of having an expert team and make it cost effective. One consultant, he can manage many hospitals, sitting in a chair, review all the new admissions. And this is the results. There was a reduction of length of stay by almost 1.2 days. There was, in ICU, there was a reduction of overall length of stay by 0.6%. Almost there was a reduction of $2,600 per case, because saving length of stay, that means saving money. And almost there was a reduction of around $1.7 million per year, and that was a very significant cost saving. So at the end, the concept is the Tele ICU will not replace the primary intensivist. If you have a primary intensivist, if you have a consultant ICU, that's fantastic. But usually we are telling, if you don't have the ability to have a consultant ICU, the technology should be able to serve you. You have a consultant from far away, he can see the chest x-ray, he can see the lab, he can see the patient. He might see depend on your level of Tele ICU, he might see the whole hemodynamics ventilator and give you the best decision in seconds, not in days, not by WhatsApp, but he can communicate with the patient or patient family, or if the patient is awake, or with the patient family, and he can communicate with the nurses and physician 24/7. So the people, they should understand, because I give this lectures the last 4 years and there is a lot of questions. Oh, how technology replace physicians. This is not a replacement. This is, if you don't have the intensivist, the technology is the best option rather than nothing. And we know in our country and every part of the world, in community hospitals, in small cities, away from the center, almost very difficult to bring an intensivist. They are very expensive. They would like to work in a big cities. So this is the only option you can communicate with them through the technology on a very organized way. You don't like type of consult by WhatsApp and he doesn't know what's the patient condition. He did not see the patients. He cannot give you the best decision. But in telecommand center, this is a very advanced way of management. This is our experience in Dr. Suleiman Habib Medical Group, which is we have done probably we have done the first Tele ICU 24/7. It was continuous 24/7. I believe is the first in the Middle East by doing continuous monitoring and managing all of our critical care units. Our concept was to deliver Tele ICU Center of Excellence, high level of supervision, quick response to reach a better clinical outcome and efficiency in our units. We have our command center in our Swedish hospital. This is our command center connected to 7 hospitals in 3 countries, in Saudi Arabia, in Dubai, and in Manama. We are almost connecting now 796 beds. We get the largest Tele ICU command center in the world by Guinness last year. So this is the largest command center in the world. And more important than the largest command center in the world is ability to run all of this type of beds. We divided our teams to 3 teams, critical care adult, neonatology team, and pediatric team with a different expertise for every section. Our experience gets published in one of the high-level journal, Telemedicine and E-Health Journal. It gets published in 2019. And this is our outcome. Initially, we have done it for adult critical care units. It was a historical study in 5 ICU units, almost 20,000 adult patients, 9,000 pre-Tele ICU and 10,000 after Tele ICU. And we were looking to the major KPIs in critical care units. Our mortality rate dropped by 19%. Our length of stay dropped by 14%, which is very significant. Our readmission within 24 hours dropped by 23%. Our re-intubation rate dropped by 27%. We have a consultant every 8 hours, consultant intensivist with a full team. They are doing an auditing, they are managing. If the other side, there is a consultant in-house, we become a second opinion service. We notify the consultants about our observation, but the decision is final for him. If there is no consultant, like 3 o'clock morning and a consultant at home, then become the command center consultant. He gives direct orders, should be carried by the specialist or resident on the site. And we believe that was very effective. And to do a quick action. In summary, we were talking about initially we are aging. I don't know, this is fortunate or unfortunate. Almost 20% of population there will be alive in 2050. So that's mean 1.5 billion. More geriatric populations are more ICU care and need more ICU beds. And of course, you have seen during Corona pandemics, how the ICU need was high. Almost 35% of shortage are around the world by 2030. So there is a 35% shortage of consultant intensivists or intensivists in general. We need to solve this supply and demand. There is a different ways, either by increased training, but again, there is a training capacities are less and you cannot produce more trainees and the training need a better quality. You can recruit more, but again, there is no way you can recruit an intensivist because of many reasons I have told you, and no enough people interested to go on ICU training. I believe the best option we have to go by technology. Technology is changing the whole game, not only in critical care, in medicine, in life, in education. And our training today is part of technology. So shortage of intensivists really it's affecting the healthcare services. There is a marked shortage of intensivists in this country as well, especially in primary and secondary hospital. Tele ICU, it's proven to be the effective way in getting the ICU better KPIs. You can do Tele ICU on a different level, by the way. If you cannot have the ability of doing fancy Tele ICU with a very fancy command center, when you see all the monitors like in Sweden with us, again, you can do Tele ICU on a very simple technology. You should have just a camera, robot, and a way of communication between the primary center and command center. And of course, you have to have a policy and procedure, because you don't want that confusion, who's responsible, who is giving the order, who is medico-legally responsible. All that had been solved since long time. I think the Tele ICU experience gonna be more and more in Saudi Arabia. Now we have a very positive experience with our colleagues in Ministry of Health. We are collaborating with them in operating 6 hospitals in Qatif, Jeddah, Medina, Kharj, and 2 hospitals in Qasim. We started the Tele ICU with collaboration with our colleagues of the ministry. They were very supportive, they were very dynamic, and I'm very glad to work with them. And I'm sure the results of the using Tele ICU will appear soon. During this crisis, already we started using robot by communicating with our critically ill patients in Uhud Hospital in Medina, in Buraida Hospital in Qasim, in Qatif Hospital in Sharqiyah, and other centers in Kharj, in Qasim and Jeddah. And I think that will be a very wonderful outcome. Thank you so much.
Thank you so much, Dr. Awad, on this really valuable and comprehensive, informative lecture that really cover a new technology that we might be able to be used and utilized actually in such a pandemic situation. Only for the questions, for that, please, if you can type your questions, and we'll start to read it together with Dr. Awad, and we'll try to find out how can we like go over most of them. So I would like to apologize for you guys for not mentioning the names. So I will just mentioning the question that I passed through. Some of the question Dr. Awad is asking about the use of this new technology and the help of that, since you are a consultant in critical care and at the same time in infectious disease and infection control. How would that help in this pandemic situation?
A very good question. If you look to Chinese technology or Chinese experience and Wuhan experience, they were using a lot of robots in delivering care. Robots in delivering food, robots in delivering medication, robots in delivering even stable patients. Why? Because it's much better than healthcare worker. You don't want to expose the healthcare worker to the infection. You can expose the robot, because what we're gonna do with the robot is just to clean it after that. But exposing healthcare worker is a much risky attitude. And again, I believe what we are doing now in our tertiary hospitals in UMOH, we are using the robots most of the time to go to the patients, to see the patients, the nurses' exposure to the patients. We're trying to minimize the nursing exposure to the patient as much as we can. Definitely, we cannot make it in critical care at 0 level, but in the ward, it's a very effective, cost-effective method in decreasing transmission of infection.
Well, that's awesome, Dr. Awad. And some questions as coming through, a lot of doctors around though asking about what are the challenges, since you have that a good experience so far now. What would be the most challenge that you face during this experience?
I believe usually if there is a will, there is a way. Always there is challenges. One of the challenges is understanding the concept, because a lot of people, they think this technology it's replace their job. No, it's not replacing anybody's job. It's not replacing anybody's job. It's helping people in completing their job. For example, this technology cannot replace nurses, cannot replace RTs, cannot replace resident and specialists. This technology only will replace consultant if there is no consultant. So this is the first concept. So it's an excellent help, not replacing people. Second is you have to have a very clear policy and procedure about who can give the order and who should obey the order, because usually it's about responsibility of critical care. I think if you close that gap with collaboration of the teams, first 3 months might be a little bit difficult, then it will fly like any other project.
Some questions are coming, Dr. Awad, through the role of the other ICU or other critical care team members, like the nurses, the RTs. How would you explain their like their role in remote or tele ICU?
I think as usual, the role of nurses are more important than my role. There is two roles of the nurses. The nurse in command center, she will do auditing, she will look to the charts, she will select the critical care patients, and she will start doing auditing all the time. So that's a very significant role. The nurse in the floor or with the patient, her role is, if there is no consultant, her role to communicate with the command center, to give them her evaluation and her needs and her concern. So on both sides, it's all about communication. If the nurses in critical care every day, she do a full assessment and she presented a head to toe round to us, from head till toe. She give us all the information, and based on the nursing information, we do our decisions, plus based on our clinical exam. So if the nurse will do the same in command center, that will be wonderful. If she have the time to give me all the information, if I can access the radiology lab, if I can access the CT, if I will see the cultures, then I will see if I am close to the patients or I am 5,000 kilometers away from the patient. That is not a big issue. My decision will depend on the information will be delivered to me.
Excellent, excellent. Very thorough, really informative. 2 or 3 more couple questions, which looking really interesting from the audience. Thank you. They were really creating a lot of really queries regarding the utilization of such technology. One question is coming: if this is effective in a Hajj mission, what do you think?
I think it's very effective, definitely. What I know, the MOH last year, they bought couple of robots in Hajj mission. According to the news I get from them, it was effective. But again, first of all, everybody should be oriented about how to use the technology. Everybody should knows there is a technology, go and ask for help. Any new program, usually it will take time till people adapted to it. And then at the beginning, usually they said, why they keep calling us, what they need from us, we are busy. But after time, when they understand the benefits, they start to call us 24/7. I believe it's very cost effective during Hajj. I believe, especially if there is a difficulty to bring in-house intensivist. And again, even if you bring in-house intensivist till 4 o'clock consultant, this is not enough. From 4 o'clock till 8 o'clock morning, you need consultant, critical care, all the time available. And this is almost mission impossible because of the shortage of intensivists. So I believe the technology will help people a lot in that regards.
Well, there are a lot of agreeing with you, Dr. Awad, regarding using the technology among, especially in the pandemic time. And I would really recommend that even during the Hajj, as you mentioned. Some of the questions are going through more details during the operating the, let's say, operating the tele ICU. How would you manage, for example, the quality of a procedures being done? How would you manage, for example, a good assessment at the bedside? So I'm just like trying to like summarizing most of the questions that are coming through the specific details. Some of the questions are going even during the ventilator change or ventilator like parameters change remotely. How did you describe that?
First of all, let's to answer this question. Are we replacing a consultant intensivist? We mentioned no.
No.
So we are comparing between no intensivist in one hand, consultant. In one hand, there is an expert around on a tele ICU. So comparing nothing to at least 70 or 80 or 90% efficient service, the answer is clear. So this is much better than nothing. Tele ICU will never be perfect, because if you have a very good consultant intensivist in-house, I would prefer that than the tele ICU. However, this is not possible. We know it's not possible. You cannot bring an intensivist 24/7 in all the hospitals of the world. It cannot be. So we have to be realistic. We should try to bring an intensivist in the morning, then we have the technology at least at night. The technology, of course, cannot examine the patient, but the people in the unit, they can examine the patient. We never had a problem in critical care procedures. Our colleagues from anesthesia always helpful. Our colleagues from different departments, they come and help. Rarely you will find the patient died because of difficulty of putting central line or difficulty of intubation or other procedures, because that might happen, but it's not common. What is common is people, they will die because of mismanagement. People, they will die because you did not apply septic shock guidelines. People, they will die because you did not put them on DVT prophylaxis. People, they will die because you did not burn them early, and the resident, he doesn't know what's the best practice for treating ARDS, severe ARDS. The resident, maybe he will delay the dialysis for 10 or 12 hours based on his short information, and the patient will die. This is usually the cause of death we see in ICU. We see VAP because the people, they are not applying very good VAP bundle. As we see in UMass, the VAP improved by almost 50% or 40%, if I remember very well. So this is the usual problems. Again, for the procedure, the only people they should do the procedure, the people they have knowledge and they are privileged to do the procedure. And I think most of the hospitals, they have people with experience doing the procedure. ICU is not a procedure. ICU is about decisions. And always decisions in critical care.
You can't imagine, Dr. Ahmed, how much questions are thrown through this technology. So people are really hungry to know about that more. I would like go with only 2 more questions. I find it interesting to be answered. Then I'll leave the stage for you to tell your last word. One of the last questions that I've seen here is regarding, did we try involving other consultations through the ICU? And would you find it helpful?
That's a very good question. We have a very good experience. We have a project run by, we own the project, Dr. Sulaiman Al-Habib project in Qasim. And always they consulted us in Riyadh because of, not ICU, they consulted us, they need hematologist, they need an oncologist, they need sometimes interventional radiologists for second opinion. And we found the Tele ICU, it's become a telehealth command center. So always Tele ICU can add more services for second opinion, neurology, cardiology, hematology, oncology, because again, it's the same concept. It's a telehealth concept. It's delivering medicine or healthcare by using the advanced technology. Because again, you don't have the experts everywhere. I can communicate today with Mayo Clinic for asking for second opinion. It's the same concept as how we can use the technology to serve our patients.
That would be really like a revolution in the kind of giving the service throughout the country. Last question, that would be through some specific special like services. One of the excited doctors was asking about probably delivering or like controlling ECMO services, telemedicine. What do you think?
Well, again, since Dr. Ayev is one of the ECMO experts in this country, I think he can answer that question. However, again, ECMO is not an easy machine. You should have the experience to run it. You should have the trained nurses, the trained perfusionists to run it. Again, you should have the consultant. You should have the backup all the time. If the team is around, if the perfusionist is around, and the nurses is around, and the experience is around, then doing a teleconsultation is not a bad idea. calling an expert like Dr. Ayed or an expert like Dr. Muhammad Azzam or Dr. Alia, or we have many experts in this country about ECMO. This will be very beneficial. However, the basic principle should be there. Not you hook a patient on ECMO and you don't have a backup and you start calling patient by tele. Now, it's not effective.
Okay, so I think we are almost reaching to the end. There are especially a lot of questions ongoing there, so I'll leave the last word for you to conclude it. I would like to thank you and thank you all the control people who were in advance with us, helping throughout the whole presentation and the whole lecture. I'll leave the stage for Dr. Awad for his last word regarding the services.
Shukran, Dr. Ayed. Thank you for the team from Saudi Council. Wonderful team. Very good preparation. Thank you for the attendees. Almost we reached 9,100 attendees. Always try to use technology in your life, of course. When iPhone came out, everything changed in the world. Again, medicine is part of life. Medicine should be getting advanced with technology like any other services. We should be open for new practices, new ideas. And I would like to thank everybody. And I will give you a good news. The Saudi Society of Critical Care will launch the first guidelines in our society history about COVID-19, about treatment or dealing with COVID-19 critically ill patients. We are at the final stage. Almost within a couple of days, we will release the guidelines. I would like to thank the board member of the society for their help. The leaders of these guidelines, Dr. Faisal Sweden and Dr. Walid Al-Hazzani, for leading this guideline and other active authors. And also I would like to thank Dr. Muhammad Sultan for his great support from Saudi Council to the Saudi Critical Care Society. And by the end of the year, we will see more Saudi guidelines, inshallah, coming soon.
Thank you so much for you, Dr. Awad. We're reaching more than 9,000 attendees. I would like really to thank again the Saudi Commission for Health Sciences for facilitating such amazing comprehensive lecture with an expert, the President of Saudi Critical Care Society, Dr. Awad, and the expert in critical care and infectious diseases. I'll leave it for you, control guys. Thank you so much for everybody. And regarding the questions for the CME hours, I think the control are answering for you guys on that. And have a nice night. Thank you so much for all.
شكرا للجميع. شكرا.